Bilingualism, a pearl to overcome certain perils of cochlear implants. This is a summary of a journal article about how it is possible to mitigate negative impacts of cochlear implantation on deaf children through the route of bilingualism. The article was written by Tom Humphries, Poorna Kushalnagar, Gaurav Mathur, Donna Napoli, Carol Padden, Rathmann and Scott Smith. Abstract. Cochlear implants, or CIs, have been deemed a success in some deaf children due to their leading to an improvement in speech production and auditory awareness. However, success is highly variable and it's difficult to truly understand success levels due to studies using different methodologies and to differences in the technology itself. If high post-surgical failure rates are being recorded, shouldn't we consider alternative approaches? Recent studies prove there is a critical period for brain development, and if language is delayed during that period, there will be a significant negative impact on cognitive and social skills. These authors suggest it is crucial that children learn sign language before, during and after the surgical process to guarantee language acquisition so that they may achieve their full potential. Introduction. The primary motivation for cochlear implantation is to enhance deaf children's awareness of environmental sounds and to support their speech development. Increased speech awareness and development are commendable outcomes but do not necessarily lead to linguistic excellence. Existing studies have shown that implanted children continue to achieve language competency below the levels of non-deaf children. If deaf children don't acquire language early enough, they are at risk of not developing normal cognitive and psychosocial skills. These risks are addressed in this article. Language development is crucial to the cultivation of other skills. If emphasis is solely given to speech development, deaf children will be placed in jeopardy. CI technology cannot provide deaf children with complete access to spoken language, but all deaf children can perceive a fluent signed language. If this exposure is granted, a foundation will be laid for robust language development. Once sign language is acquired, it can be used to support the acquisition of a spoken language. Simultaneous development of two languages, one signed, one spoken, allows transfer between the two. In other words, proficiency in one language promotes proficiency in the other. The authors propose that implanted children be given the opportunity to acquire both a signed and a spoken language in order to achieve their full linguistic potential. Epidemiology and CI, a global issue. Most deaf people have sensorineural hearing loss, SNHL, which is a permanent loss in the inner ear or sensory organs, for example, the cochlea. Globally, SNHL is among the most common birth conditions labelled defects by the general medical profession. Statistics show significant numbers of children worldwide have SNHL. Systems in place in North America and Europe mean that babies are screened soon after birth and, if identified, immediately referred for audiology, followed by surgical intervention. Audiologists and surgeons are almost always hearing professionals. It's extremely rare for a child to be referred to a successful deaf professional with experience and expertise in sign language and bilingual education. Cochlear implantation is now the primary treatment for deaf children. Sign language is seen as symptomatic of treatment failure. Studies tend to focus on speech and auditory skill, rather than investigating language and communication ability. One reason for this appears to be mainstream hearing communities perceiving speech and language as one and the same thing. Many people don't realise that signed languages are true languages. I'm worried that deaf children's lives will be made doubly difficult if they communicate that way. This leads people to seek treatments that will help deaf children appear as close to normal as possible. However, if focus is placed on a combination of both spoken and signed language, this can be more effective in resolving any difficulties of language development. Potential benefits of CI. Cochlear implants can help to enhance awareness of the different speech sounds. They may also help children differentiate between sounds, whether sounds are loud or soft, continuous or intermittent, long or short. They may also help children work out how many sounds there are, how many sounds within a particular word, how many syllables in a sentence. They can support recognition of environmental sounds, such as a door being knocked or an emergency siren. Some deaf children with CIs can even recognise speech in quiet surroundings when given multiple choice answers to select from. Far fewer deaf children with CIs may be able to perceive speech in an open environment. CI aims. The hope is that an implant will aid speech production and reception, thus allowing social, academic and professional interaction with hearing people through spoken language. Development of a spoken language can help improve career prospects and social opportunities. Spoken language ability may also lead to enhanced literacy skill. Some studies show a correlation between phonological awareness and reading skill in deaf children and adults. However, phonological awareness does not guarantee advanced literacy in deaf children. In fact, some studies have shown a correlation between sign language fluency and reading achievement. Bilingual ability has also been shown to correlate with reading skill. In summary, speech ability is one contributory factor for reading success, but many deaf children will never achieve fluency in spoken language. We should therefore not focus all energy on speech development, and instead focus on good language development, whether the language is spoken or signed. Put simply, good language ability leads to good reading. Potential perils of CI, particularly in the absence of sign language. Cochlear implantation is major surgery, and all major surgery carries a risk. Successful implantation depends on a number of factors. For example, age at implantation, duration of deafness, processing strategies used by the child. It has also been established that surgical technique can affect outcomes. Other factors, such as high socio-economic status of parents, can lead to better outcomes. Additionally, sustained attention to the rehabilitation process is crucial. Post-surgical rehab is essential because CIs do not allow immediate speech comprehension. Training is required for a recipient to make sense of novel auditory sensations. However, there's danger in treating this solely as a rehabilitation process. Language development is not rehab and needs also to happen naturally. Prior to surgery, it's impossible to tell which children will benefit the most. Some children will gain no linguistic benefit, while others will become fully integrated into a hearing environment. Some research suggests that implantation can lead to disorders in neural activation. It has also been shown that CI users experience fatigue due to the intense cognitive effort required to use them. Children will often take great strides in the early stages, but later fall behind their hearing peers. Due to these many issues, the best way forward is multimodal, speech and sign for all deaf children. The greater peril of CI without sign language, linguistic deprivation. Too often when people think of language, they think of speech. However, the language faculty in the brain is flexible with respect to modality. Whilst true that the brain is flexible, there remains a critical period within which language development must take place. The first really critical period leads up to the age of 6 months. Language input during this period plays a crucial role in the development of auditory processing. It is therefore vital that exposure to any language takes place within a baby's first 6 months. The next critical period goes up to the age of 5 or 6. If language has not been acquired by this age, it will be impossible to acquire fluency in any language later in life. This means that with delayed exposure to fluent language models at an early age, deaf children are placed at significant risk of linguistic deprivation. Language development is so important because it supports the development of other skills such as theory of mind and executive function. Therefore, if language is delayed, deaf children are placed at high risk of long-term cognitive difficulties. Language delay can also lead to serious difficulties in developing a healthy sense of identity and a positive perceived quality of life. Deaf children who are unable to communicate are placed at much greater risk of physical, emotional, and sexual abuse. In summary, ensuring deaf children have exposure to accessible, natural language from birth is a societal responsibility. To ignore this places large numbers of deaf children at high risk. Bimodal bilingualism, the optimal approach. The most reliable way to ensure best possible long-term outcomes for deaf children with CIs is through bimodal bilingualism. Bimodal bilingualism means children acquire proficiency in both a signed and a spoken language, the spoken language being acquired at least in its printed form. Some deaf children will demonstrate spoken language fluency via speech. Others will be better able to demonstrate it through the printed form. Either way, it's fluency in the spoken language that is imperative, alongside fluency in the signed language. Bimodal bilingualism and language development. During the critical period for language acquisition, bimodal bilingualism helps parents to focus on language development rather than just speech development. Numerous studies have shown that linguistic milestones follow the same path for deaf children acquiring a signed language as that of hearing children acquiring a spoken language. Early sign language exposure brings with it a number of advantages, such as strengthening sensory motor pathways in the brain, facilitating early development of spatial attention, ensuring the brains of deaf children follow normal language development pathways, so when the time comes for implantation, they are primed to acquire spoken language. If deaf children acquire a signed language, compared with no language at all prior to implantation, they will be in a much better position to acquire a spoken language. An added advantage is that pre-implant exposure to visual language harnesses children's natural desire to communicate through gesture. This is evidenced by baby signing classes being so popular with parents of hearing infants. Bimodal bilingualism and academic achievement. Deaf children who use sign language, with or without CI and regardless of family background, demonstrate greater academic and reading achievements than those with no sign language. In particular, signing skill correlates strongly with reading achievement above all other possible factors. Deaf bilinguals show more creative verbal processes for syntactic structures, more creative thinking, compose more complex sentences, and have higher accuracy in attention switching. Bimodal bilingualism and social psychosocial well-being. Deaf people who are able to sign and speak can communicate and socialise with both deaf and hearing people. Bimodal bilingualism promotes positive, long-term psychosocial outcomes in deaf people. Deaf children who have a strong culturally deaf identity or a strong bilingual bicultural identity have the highest self-esteem and best mental health throughout life. Bimodal bilingualism and social justice. Deaf people experience many inequities within society. The bimodal bilingual approach lessens or prevents these inequities. CI success strongly correlates to higher socio-economic status and parental speech characteristics. However, with sign language added to a child's repertoire, the attainment gap relating to socio-economic status is reduced. Hearing loss is more prevalent among families and countries of lower socio-economic status. Bimodal bilingualism and personal justice. A bimodal bilingual approach is based on the evidence that sign languages are natural languages that are visually accessible to deaf children. All children, whether deaf or hearing, need and deserve a fully accessible language that they are free to comprehend and to articulate at will. The right to language is the most crucial of human rights. Communicating with a deaf child in only the spoken modality places limitations on the child and makes language acquisition unnecessarily effortful. Deaf children should not be expected to achieve complete access to speech via hearing aids or cochlear implants, but these expectations prevail throughout the early critical acquisition period. Implementing bimodal bilingualism as a clinical and system intervention. The first of this two-step process is education. We must educate the general public to the fact that language development begins before speech development, and that the crucial language development period is in the first few years of life. We must also educate professionals in the fields of audiology, speech-language pathology, and related professions to the benefits of bimodal bilingualism, and ensure that they are given clear research evidence to support these claims. Professionals should follow a 6-step process. 1. Ensure hearing screening occurs with appropriate follow-up. 2. Refer families to appropriate healthcare specialists. 3. Identify warning signs that children are not thriving in their present language situation. 4. Collect and disseminate accurate information on deaf issues. 5. Advocate for the child, whilst at the same time supporting the parents. 6. Provide families with information on learning sign language and on the educational rights of the child. The second step to implementation is cooperation and coordination. Health professionals should cooperate with the deaf community and recruit bilingual deaf adult role models. Deaf adults who grew up deaf carry important lessons about how to best meet the needs of deaf children. Health professionals should promote and lobby for local, national, and government support for bimodal bilingualism. Conclusions. Raising a deaf child with CI and exclusively spoken language risks delays in language and cognitive development, as well as academic and psychosocial difficulties. Raising a deaf child with CI and both a spoken and a signed language enables successful bimodal bilingualism, avoiding myriad potential problems. Bimodal bilingualism is the safest way to raise deaf children, ensuring they achieve their full linguistic potential regardless of their socio-economic status or other factors. This will also offer the optimal chance for maximal cognitive development, academic success, and psychosocial well-being.